Hello, my name is Milan Samraj, and I will be presenting this short supplement to accompany our chapter entitled Anesthesia in the Geriatric Patient in this edition of Human and Wind's Neurological Surgery. We will briefly discuss some of the main age-related pathophysiological changes that occur in the various organ systems and touch upon their significance to anesthetic practice. We'll go through changes that occur that are relevant for the cardiovascular system, the respiratory system, the renal system, gastrointestinal and hepatic systems, musculoskeletal system, and the central nervous system. Populations across the world are aging at an increasing rate. This is due to a combination of increasing longevity and more developed healthcare systems. The number of neurosurgical procedures being performed on elderly patients aged 65 and above has also been increasing over the last few years, and this trend is likely to continue in the near future. This is true for all procedures across the board in cranial and spinal neurosurgery, but also in particular for certain procedures that specifically address pathologies commonly seen in the elderly, for example mechanical thrombectomy for ischemic stroke and kyphoplasty and vertebroplasty for fragility fractures. The human body undergoes many age-dependent physiological changes affecting almost every major organ system, with resultant decreases in overall physiological reserves. We hope that a brief yet systematic understanding of some of these pathophysiological changes will enable timely consideration of these factors before and during and after anesthesia for neurosurgical procedures, with the aim that it would lead to better outcomes and increase the safety of neurosurgical procedures being performed in elderly patients. The aging process affects almost every part of the cardiovascular system. In terms of the vessels, you get stiffening of connective tissue and a phenomenon of decreased responsiveness to beta receptor stimulation. The connective tissue stiffening affects all the major veins, arteries, and also the myocardium, making them less compliant. The physiological sequelae of these changes are such that arterial stiffening leads to chronic hypertension and increased afterload. Ventricular stiffening leads to diastolic dysfunction and impaired early diastolic filling, and the venous stiffening impairs venous compliance and the body's overall ability to buffer sudden changes in blood volume and blood distribution, and thus affects cardiac preload. The diminishing responsiveness of the aging heart and vasculature to beta-adrenergic stimulation reduces the overall contractile response of the myocardium and heart rate, especially when there's increased demand such as in stress and exercise. Age also affects the cardiac conduction system as well as the autonomic nervous system's responsiveness. Cardiac valves too are affected. A common phenomenon is aortic sclerosis, where the aortic valves undergo thickening and calcification. Such patients are therefore more susceptible to overall reduced blood volumes, which can lead to myocardial ischemia. Therefore, the main take-home message is that elderly patients, in terms of cardiovascular age-related changes, are more susceptible to myocardial ischemia due to sudden volume loss, are more susceptible to having poor cardiac output, and are more susceptible to developing arrhythmias, which can sometimes be lethal. Understanding these pathophysiological changes are therefore of paramount importance, not just for the anesthesia provider, but also potentially for the neurosurgeon performing an emergent neurosurgical procedure, for example, trauma craniotomy. With aging, the lung parenchyma undergoes histological changes very much akin to emphysema. There is uniform enlargement of air spaces, leading to a reduction in alveolar surface area. This also leads to a decrease in parenchymal elasticity, with a functional effect of decrease in elastic recoil, which is the passive inward force responsible for decreases in lung volumes during expiration. Osteoarthritic changes can affect the costovertebral joints as well as the thoracic spine, often leading to kyphosis and height loss due to dehydration of the intervertebral discs. This age-related remodeling of the chest wall leads to a reduced curvature of the diaphragm, which is the principal muscle involved in respiration. And the diaphragm, along with the other intercostal muscles and accessory respiratory muscles, undergo atrophy and weakening as well during aging. The regulation of breathing is also affected in the elderly. There is an approximately 50% decrease in responsiveness to hypoxia and hypercapnia compared to younger individuals. Loss of pharyngeal muscular support also occurs with aging, particularly in the hypopharyngeal and genioglottal muscles, which predisposes elderly patients to upper airway obstruction. Thus, we can see that elderly patients undergoing anesthesia are more susceptible to aspiration events. Complications and poor outcomes can therefore be somewhat prevented by paying attention to patient positioning during surgery and considering employing active measures such as alveolar recruitment strategies during intraoperative mechanical ventilation, and utilizing postoperative incentive spirometry, encouraging early mobilization, and consideration for the judicious use of postoperative adjuncts like CPAP or BiPAP in selected patients. Normal aging processes such as glomerulosclerosis result in renal cortical atrophy and therefore overall reduction in renal cortical mass. Whilst serum creatinine levels in elderly patients may appear within the normal range, commonly seen reduction in lean muscle mass also needs to be taken into account. Therefore, a normal creatinine level may in fact be masking a reduced glomerular reserve, and therefore sensitivity to nephrotoxic insults such as hypoxia and hypovolemia. The neuroendocrine homeostatic mechanisms of the kidneys are also affected by aging, such that the normal renin-angiotensin system's regulatory responses are more blunted than in younger individuals. Thus, elderly patients are more susceptible to electrolyte and acid-base disturbances, especially dysnatremias. Urological disease is also particularly prevalent in elderly populations. Prostate cancer and benign prostatic hypertrophy are common pathologies in elderly men, and in elderly women, decreased estrogen levels leads to vaginal atrophy and perineal skin fragility, thus predisposing both sexes to increased incidences of urinary tract infections in the perioperative period. Neuromuscular degeneration seen with increasing age affects the upper GI system, including the oropharynx, esophagus, with an impaired ability to coordinate complex reflexes responsible for effective swallowing. This failure to coordinate these reflexes can lead to several pathologies such as diffuse esophageal spasm, achalasia, and reflux. These are important considerations in elderly neurosurgical patients as they increase the risk of perioperative aspiration events. Many structural changes are seen in the gastrointestinal tract, both in the small bowel and in the colon. In the small bowel, it has been observed that there is an age-related decrease in the height of villi, with a resultant decrease in overall surface area available for absorption of nutrients. In the colon, weakening of the muscularis propria in particular, an area where blood vessels cross transmurally, are predisposed to the formation of diverticula, and therefore diverticular disease is one of the more common age-related gastrointestinal diseases that contributes to heart stool, fecal impaction, and constipation, all of which are common complaints in the post-operative neurosurgical patient. The liver decreases in both size and function. After the age of 50, the liver can decrease from 2.5% of total body mass to as less as 1.5%, both as a result of decreased hepatocyte numbers, but also due to decreased hepatic blood flow with age. This reduction in hepatic blood flow in particular means that the elderly liver's ability to metabolize drugs cleared by phase 1 pathways is reduced. It is important to bear in mind as certain drugs, which are commonly used in anesthetic practice, whose clearance is dependent on hepatic metabolism, can persist in the body and accumulate for long periods of time in elderly patients. Such drugs are ketamine, flumazenil, morphine, fentanyl, sufentanil, and lidocaine. On average, muscle mass declines by roughly 1% each year, with muscle strength decreasing at a disproportionately faster rate. Declining muscle strength and mass is linked to increased mortality and therefore prolonged bed rest, either instituted or secondary to pain or decreased consciousness in neurosurgical patients can have hugely deleterious effects. Osteoarthritis and osteopenia is extremely prevalent in the elderly, which over time leads to limited range of motion in joints. Therefore, when positioning elderly patients for neurosurgical procedures, one must take this into account so as not to exaggerate unaccustomed joint positions. Osteopenia and osteoporosis in its severe form is also of vital importance, particularly for many spinal surgical procedures involving spinal fusion. Whilst lean muscle mass tends to decrease with age, a patient's total body weight may remain somewhat stable over time. This is because total body fat content tends to increase. Therefore, for lipid-soluble compounds, which includes many anesthetic agents, this has important implications as the volume of distribution is also increased. The insulating subcutaneous fat reserves, however, decrease in volume and distribution. This phenomenon, together with dysregulated cutaneous microcirculations in elderly patients, explains why elderly patients are more susceptible to intraoperative temperature changes, and therefore depend on artificial cooling or heating methods to control core body temperature. The cutaneous microcirculation is also important in wound healing, and therefore perioperative considerations to optimizing core temperature control has wide-ranging influence in avoiding wound complications and promoting good healing. Dementia in elderly patients presents a unique challenge for anesthesiologists and surgeons caring for geriatric surgical patients in terms of communicating risks of surgery and also in engaging patients in the consent process, in obtaining information that is necessary for preoperative optimization of comorbidities and in aspects of postoperative care that are important in achieving a good functional outcome and also in preventing adverse events such as mobilization, rehabilitation, and pain management. Preoperative optimization of comorbidities, along with attention to modifiable risk factors, for example, ensuring adequate hydration, increasing mobility, reducing sleep deprivation, ensuring easy access to functional aids such as hearing aids, glasses, and walking sticks, and avoiding certain medications that can trigger delirium, for example, benzodiazepines, dihydropyridines, and antihistamines, are all beneficial in preventing delirium in this patient group. Mood disorders, especially depression, is highly prevalent in the elderly population and can predispose to adverse outcomes such as postoperative cognitive decline, delirium, and even adverse cardiac events in the postoperative period. Therefore, recognizing these mood disorders preoperatively and addressing them can therefore play an important preventative role.